in parathyroid gland. MWA is a safe and effective minimally invasive treatment for benign thyroid nodules. It can preserve the thyroid function without lifelong medication from surgery.
Yes?
Okay, thank you. So please let me thank Canon Company in the person of Adrian Zhang and Oliver Shen, and also Tommaso Galli, that is the Italian distributor for Canon Company. I'm really honored to present my experience in Italy with the use of microwave devices by Canon Company. As you told me, as you mentioned before, in introducing myself, I have only to explain that my activity in using microwave ablation is the experience of an endocrine surgeon. I'm not an interventional radiologist, but I think that I started my professional activity more than 40 years ago as a surgeon, but involved also in ultrasound-guided procedures. So it's about 40 years that I started with procedures in my old hospital in 1998, so that I started with the laser ablation, then with radiofrequency, and more recently with microwave ablation. So I think to have a very good experience with all the interventional ultrasound-guided procedure treating thyroid nodules. Now, starting with my presentation, actually, you know that surgery is still considered a very good procedure with a very low rate of complication in centers with a very high volume of procedures. But anyway, surgery reduce the quality of life because it needs the general anesthesia to incise the skin, so we will have a scar in the neck, and we need to give the patient a lifelong therapy treatment for replacing the absence of the thyroid gland with the levothyroxine, with the thyroid hormone, so that reduce anyway the quality of life. So that this is the reason that nowadays the interventional minimally invasive, also defined savior thyroid techniques are spreading all over the world, starting from the Eastern country to the Europe and then to the United States and so on. Actually, the indication for surgery are for symptomatic nodule thyroid disease, nodules that have been classified benign at cytology, or nodules with calcitonin levels higher than established, and for nodules that are suspected to be malignant, so Bethesda class 3 and 4, 5 and 6. According to the ETA, the European Thyroid Association guidelines, actually we consider that the minimally invasive procedures, thermal ablation and also ethanol ablation, are recommended for the treatment, in the case of ethanol ablation, for the treatment of the dominantly cystic thyroid lesions, while thermal ablation is considered and recommended for the treatment of solid benign thyroid nodules that are compressive, so that cause local symptoms, as an alternative to surgery, and also for people having some aesthetical discomfort, for example. We will see during the presentation what we need to prepare the patient such indication regarding the preparation and also the exams that we need to perform before thermal ablation, and something also about the follow-up and the how to proceed to follow the patients after the procedure. First of all, have a look to the indication, what nodules to treat. This nodule is a spongiform nodule, is a mixed nodule with some colloid fluid collection inside this one is considered one of the best candidates for thermal ablation. Actually, there is no more the limit up to 3 centimeters to be treated this nodule, for this nodule to be treated, because we can also consider to treat larger nodule, splitting the treatment in more sessions. And also it's important to consider that we can treat nodules that are very deep in the neck, for example, nodules that are approaching to the superior cervical mediastinum, because we can treat before the cranial part, the upper part of the goiter. Then we wait for 1 to 3 months that the deeper part will tilt up, because to the fibrosis, the scar of the treatment, after the treatment of the upper part, so the deeper part will tilt up, and you can treat very well and in a safe way also the deeper part that you cannot treat before. We can treat the autonomously functioning thyroid nodules. We consider for these pathologies to treat the volume up to 12 to 15 milliliter, because according to the international guidelines and the literature, the evidence-based medicine, these kind of nodules up to 12 to 15 milliliter are best candidates to be treated in a single session with a very good shrinkage of the nodule, but also with the full recovery of TSH, so with the defunctionalization of the nodule. In other cases, when the nodule is very big, it's considered to treat them in more sessions, or to use what we say as a combined therapy. So we can treat the nodules in order to achieve the best shrinkage, then to give a very small dose of radioiodine to fully recover the TSH. We can also consider to treat some patients with Basedov, with Graves' disease and toxic multinodular goiter, even if there is not a well-recommended procedure according to the guidelines, but also applying 2 or 3 sessions to reduce the volume of the Basedov of the goiter. You can also apply the combined therapy and give the patient a very small dose of radioiodine to completely recover the TSH level, so to achieve the best results in terms of shrinkage, also in terms of function, of thyroid function. You see here some cases that we treated with thermal ablation, a very high vascularized nodule. We identify, because we apply in this case a so defined technique, the ablation of the afferent artery before the treatment. This could be applied with radiofrequency. The first paper we published were written using radiofrequency, and then we applied also for microwave, never used before. And we applied the treatment, the ablation of the artery before starting. We identify with the color Doppler and pulse Doppler the main afferent artery. Then we insert the tip of the needle inside the capsule of the thyroid gland, very close to the artery. We turn on generator and we apply the energy in order to completely destroy the vessel, the vessel lumen. And you see that immediately after the ablation of the artery, we see this black area. That means that we have completely devascularized, deprivated the nodule from the vascular supply. You see here the images of the CT scan with the very hot nodule on the right side, and after the treatment, at the follow-up, we see that the nodules became fully hypocaptant or cold to CT scan, and with recovery of the function all over the thyroid gland. This is the scar after the treatment at 3 to 1 year after follow-up. Some images with power Doppler evaluation of the vascularity of the nodule before the image of the we identify the main afferent artery, and we treated it, as you can see, with the power Doppler image. And this is the evaluation after the treatment. You see the typical pattern of the nodule after microwave energy that has been applied. All the nodule is fully deprivated from the blood supply in the longitudinal scan and in transversal scan. But this is very important to consider. For a nodule of 10 milliliter, we use 18-gauge microwave antenna, and we applied only 20 watts for 40 minutes and 40 seconds with the total amount of energy delivered that is 5,600 joules. So with a very low delivery of energy, we are able to fully treat and defunctionalize this nodule that only after 1 month, you see here, became 3.8 milliliter and was fully avascular, identifying a very well done treatment from the point of view of the shrinkage, or not only, but also from the point of view of the functionalization of the nodule. Some words about the indeterminate nodules, that means type 3. Differently from type 4 and the other classification, type 5 and type 6, that go directly to surgery, type 3 could be considered for follow-up, and also for a further study evaluation with genetical tests in order to to understand if there is any genetical mutation that can increase. Sorry, I need some water. Okay, in order to evaluate if there is any genetical mutation that can increase the risk of malignancy. Well, according to the international guidelines, how can we manage it? We should manage these nodules as if they are a cancer, because nowadays we don't have any recommendation that identify a very well done treatment with thermal ablation. But maybe that in the next guidelines should be considered for treatment type 3 nodules that are wild type, in other terms, that are that present no genetical mutation. So from this kind of view, we could treat this nodule with a very well done follow-up after the treatment with the thermal ablation. This could be a perspective of the immediate future. But also the landscape of the treatments with the thermal ablation has recently improved with the introduction of this procedure for the treatment of malignancy. In this case, I'll show you some images of a small microcarcinoma that is very close to the capsule. This is a very tricky case in a very young people, a very young guy, and we decided to treat because this patient was determined to be treated with thermal ablation, and he absolutely refused any kind of surgery because according to international guidelines, this microcarcinoma should be applied for thermal ablation in the respect of the guidelines similar to the active surveillance. In other terms, the best candidates for microcarcinoma treatments should be nodules single in the lobe with no other nodules in the other lobe that are not so close to the capsule, with at least 1 to 2 millimeters from the capsule, absolutely not so close to the deep capsule because it's very tricky that area to treat, and with no evidence of other nodules, as I mentioned before, and of lymph nodes, of potential metastatic lymph nodes. In the literature, there are a lot of papers about this treatment, and also in this systematic review that I show here and meta-analysis, it can be observed that thermal ablation techniques for treatment of T1A and 0M0 PTC are very effective and also equally effective when compared with surgeries in terms of local recurrence and the presence of lymph node metastasis, but with a very better profile regarding safety and the reduction of complication, so that thermal ablation could be considered as an excellent therapeutic alternative in selected patients. We can also consider thermal ablation for the treatment of lymph node metastasis and for recurrences after surgery. This is a very new aspect of this treatment that we are deepening. In my hospital, we have a lot of patients coming from other countries from other institutions that were previously treated with 2 or 3 surgeries, and they refused to have a new surgery when presenting the lymph node metastasis or recurrence, and we can apply them for the treatment with thermal ablation with very, very good results. And I think that microwave device 18 gauge, as we usually use in this case, is a very effective and very handy procedure for the treatment of these lesions that sometimes are very difficult to treat due to the presence of fibrosis scar, but with a very thin needle that is available with Canyon, we can do in a very safe way and have very excellent results in the follow-up. But now we enter in the most important part of my presentation regarding safety. I think that this is one of the most important topics, because this treatment should be considered as safe treatment without any kind of important complication. But this is up to you, because independently of the thermal ablation energy source you use, that could be radiofrequency or laser or microwave, anyway, to reduce the risk for complication and to be safe, you need to strictly apply the recommended protocol for each technique. That means for microwave, as for like for radiofrequency, to apply the moving shot technique, introducing the needle from the middle line with a transsystemic approach and apply small spot of necrosis all around the nodule in order to achieve the best results in terms of shrinkage. But you will see also that with microwave, we can use the stationary technique, so that means that applying the introduction with the same technique from the middle line and to transsystemic approach, we insert a thicker device like the Canyon 16 gauge, and then apply protocol according to the relation between watts and time in order to achieve a spot of necrosis that can vary in centimeter according to the time of application, the energy that we deliver. There is a very well done algorithm available from Canyon in order to decide how many minutes stay delivering energy, and so you will foresee the area of necrosis that you can reach after the treatment. So this is a very important topic. You need to apply always the technique that is recommended by the international guidelines. To do this, to be safe and to be skilled, we recall the best practice recommendations implementation, because the operator needs to be skilled, and it needs to be skilled after a very good, well-done training learning curve, starting from the ultrasound scan of the thyroid, then to the fine needle aspiration biopsy procedure, because I think that fine needle aspiration biopsy is the mother of all the intervention technique. Then, when the operator is very skilled with this 2, you can apply for a course for a master class with microwave thermal ablation procedure, starting from the presentation, scientific presentation, then the training on some dedicated model like this from SurgeMate is very good because it presents the same anatomical model of the thyroid gland and the presence of nodule inside that you can simulate very well the treatment with the device. This model are very effective to start this training model because you can then apply after I've seen the treatment in the operative rooms with your trainer. You can apply to start with persecting, to start to treat the patient with the trainer besides you in order to be very, very safe. So I think that safety is the most critical issue, and to be safe, you need to be skilled, observing a very well done learning curve, and only after this you can treat by yourself your patient with microwave thermal ablation. Some slides about the treatment of thyroid nodules, what we need to do it. First of all, physical examination. Please evaluate the patient from all the points. So regarding the clinical evaluation, symptoms, aesthetical discomfort, medication, comorbidity, and so on. So perform a very well done ultrasound examination with a very good ultrasound machine in order to evaluate all the details of the thyroid pattern. The lab tests are very important to identify abnormality of the thyroid function, and then fine needle aspiration biopsy. According to international guidelines, we need two consecutive fine needle aspiration biopsy that should be tied to, so benign, except when we have spongiform nodule or autonomous functioning thyroid node. In this case, you can need only one fine needle aspiration biopsy to perform, benign obviously, to perform the procedure. We don't consider the centimeter, but we consider the milliliter, because to start a treatment, before starting a treatment, we need to evaluate the volume of the nodule. So please don't consider to give only the measure in centimeter, but mainly the evaluation should be done with the volume in cc's or milliliter of the nodule, so that you can follow up the nodule, establishing the shrinkage in milliliter after the procedure at determining points of the follow-up 1, 3, 6, and 12 months, and then once a year in the further years. We need to prepare regarding safety. We need to prepare with a sterile field everything. We put adhesive cover probe and also a transparent dress on the keyboards of the machine, of the ultrasound machine. We start with, after this sterile preparation, we start with the most important part of the treatment, that is the local anesthesia. As you see here, we introduced the needle to the transsystemic approach, and we applied the tip of the needle on the white line that is the capsule, and so that we inject the local anesthetic, separating the deep fascia of the strap muscles from the white line of the capsule, creating an hydrodissection that should be done with lidocaine 2%, 10 milliliter plus 10 milliliter of saline solution. By this way, we create a fluid collection separating the field, the two fields, the muscular and the gland part. So we hydrodissect in order to reduce the risk for adhesions and to injury the muscle during the procedure. And in the same way, we apply local anesthesia to reduce the pain. This treatment is absolutely painless, because the only area where we can find sensitive nervous fibers is on the capsule. So when we hydrodissect with the lidocaine, we can have a very painless procedure, because inside the nodule there aren't sensitive fiber that could give pain sensation to the patient. This is the right way to apply the local anesthesia. This is a not good procedure, because you see that in this case we are injecting the fluid, the anesthetic fluid, not between the muscle and the capsule, but inside the muscle. So in this case, the procedure will be not painless because of the wrong procedure that was performed. In some cases, we can also need small, in very few cases, we could need a very light sedation, conscious sedation of the patient, but only if the patient is very anxious, in order to let him be calm and relax during the procedure. We don't recommend any kind of general anesthesia, because the patient needs to cooperate with you, and you need to hear any kind of voice change during the procedure in order to foresee any kind of complication that could happen during the thermal ablation. This is the technique that I explained you before, the introduction of the needle through the middle line with a transsystemic approach, reaching the deeper part of the nodule, delivering a very small spot with low energy in the deeper part, saving this small area that is defined as the dangerous triangle, where we can have trachea, the laryngeal nerve, the esophagus. Here we can have the phrenic nerve, and here we can have, between the carotid artery and the jugular vein, the vagus nerve. So in this area and in this area too, we need to be very, very safe and careful, delivering only small spot of energy. Then we move back the needle, and we can treat the internal part of the nodule with higher level of energy in order to achieve the best results at the end of the procedure, when all this spot of necrosis will merge and giving us a very well done necrosis area of the nodule that we have treated. Some consideration about the laryngeal nerve. Consider that differently from the left side, where the laryngeal nerve runs very close to the trachea, coming up from the mediastinum. On the right side, the laryngeal nerve could be not so close to the trachea, in the immediately exiting from the thorax. So in this case, the concept of the dangerous triangle very close to trachea is true for the area very close to the cricoid, while when we treat the very deep nodules approaching to the mediastinum, we should be careful not only with the medial aspect of the dangerous triangle that we can see here, but also we must be careful on the deeper part, on the posterior wall of the thyroid, because in this case, on the right side, the laryngeal nerve runs not so medially, but posteriorly to the nodule. So consider also that the anatomy of the neck is one of the most important things to very well know. Some slide about the steps of the procedure, the local anesthesia, then the needle. This is not the microwave needle, but sorry, I have this slide already good for presentation. The insertion of the needle through the short axis. Please consider to enter the nodule only to the short axis with a in-plane technique, because the introduction along the long axis is not recommendable, because it's very, very dangerous. Then we apply a transparent dress on the neck, because we could also evaluate with the ultrasound the thyroid and vocal cord movement without removing the gauze of the typical dress. And then we apply a nice pack on the neck in order to reduce local temperature. I would like also to show you the technique of hydrodissection, because this is a very important technique that we can apply during the procedure in order to create, as in the case that I show here, to create a fluid collection, not only from the muscles and the anterior wall of the capsule, but also from the posterolateral aspect of the nodule, so that we decide to introduce, in this case, let me see, to introduce the technique of hydrodissection, injecting a fluid that could be dextrose 5%, or as we usually do now, injecting the mannitol. You see here the tip of the nodule crossing the entire nodule. We prefer to have the same approach for all the techniques. And when we are very close to the deeper posterolateral area, we identify the area where injecting, where the black area will be evident. It means that we are injecting, we are hydrodissecting. And you see here how slowly this space of fluid collection increase in volume, separating the nodule from the deeper area. So not only from the vessel, but from the vagus nerve, the cervical brachial plexus, and so on. It's a very safe technique to reduce the number of complications that we can have after the procedure or during the procedure. We can also apply for translaryngeal. I'll show you in this. Sorry, I went for translaryngeal ultrasonography in order to evaluate the movement of the vocal cords. I'll show you in this video where the technique is very well explained for a microwave thermal ablation of a nodule of 28 cc's. We perform fiber optic laryngoscopy before in order to assess the vocal cord movement before starting the procedure. You see the regular vocal cord movement. We prepare everything with the probe that is covered with a sterile drape, an adhesive sterile drape that I'll show you. This is the transparent dress on the machine. Now we apply the probe without gel, so we increase the resolution of the image without any kind of interference. Then we prepare the syringe with lidocaine and with mannitol. Then the position of the patient on the bed, that is like for surgery, slightly hyperextended with an half-seated position on the bed, in order to achieve the best position to explore and to treat the area, but not interfering with the comfort of the patient. Then an ultrasound scan of the neck in order to identify all the details and mainly the volume. You see here we are evaluating the volume with anteroposterior and transverse diameters, then with the longitudinal scan. So the formula for ellipsoid area is evaluated with a total volume of 28 milliliters. Then we evaluate the vascularity. You see here with the power Doppler examination, it's a very well vascularized nodule with the peri and internodular vascularity, and try to identify the main afferent artery in order to achieve the best results, deprivating the blood supply of the nodule. This is the microwave device. We use in this case an 18 gauge device that is the thinnest available in the market, and is produced by Canyon company. You see here the technique of the anesthesia, the hydrodissection with lidocaine 10 cc's plus mannitol 10 cc in order to create a very well done fluid collection, and also to let the anesthesia will stay longer, and also the hydrodac section stay long in order to avoid any complication with adhesions between the nodules and the mask. And then we massage in order to diffuse the anesthesia, a very small incision with the tip of a scalpel in order to facilitate the introduction of the needle inside. Then you see here that we start reaching the area with the main afferent artery that is on the upper pole. Then we deprivate the blood supply of the nodule. With this technique, this sound that you hear, it's the sound that you have during the procedure each second. And you see here that the upper part of the nodule was fully treated because there is absence of vascularity, so the afferent artery was completely ablated. Then we start with the treatment of the section of the nodule, because you have to divide the nodules in such a compartmental way to consider for the treatment, starting from the upper part or from the lower part is not important, it's up to you. And then to complete the treatment for all the entire volume of the nodule. When we have a large fluid collection, we can aspirate them, as I showed you before. Then we can treat applying the energy of a microwave inside. I try to go fast because the treatment lasted about 15 minutes. You see here the treatment of the large fluid collection that we previously aspirated. And you see that proceeding with the treatment, all the nodules become not only hyperechoic, because the hyperechogenicity that we will have during microwave will last not so long like for radiofrequency, for example, but you very well will see the treated area from the untreated area, because they become very soon hypoechoic when compared with the previous images before the treatment. At the end of the treatment, you see that all the nodule is fully devascularized, and we are going to treat also the veins, the capsular veins on the periphery of the nodule in order to complete the vascular technique. As you see here now, it's reducing the vascular, we have reduced the vascular supply, but also we reduce the vascular drainage of the nodule. This is at the end of the procedure. With the B flow, there is absence of vascular signal inside the nodule that we have treated. This is a combined evaluation. And then is the translaryngeal ultrasound examination. You see the movement of vocal cord. You can do this during the procedure, and you can do this after the procedure in order to evaluate everything. Then the transparent dressing to cover the area of treatment, and the ice pack to reduce the local temperature and give more comfort to the patient. So some more case of a microcarcinoma. You see the case of this microcarcinoma with 1 millimeter from the capsule with this ultrasound aspect. It was a nodule that we treated with microwave, and this is the result after 1 year. There is no evidence of the nodule in the different steps of the treatment. The treatment with the device, or obviously the treatment is greater, the area of necrosis is greater than the area of the nodules itself, and these are the steps during the follow-up. You see that when we start with the follow-up, immediately at 1 month, we will have a greater nodule with a scar. Then we will perform a fine needle aspiration during the follow-up at 3 or 6 months in order to understand if there is any presence of thyroid cell, in this case without any thyroid cell, without any malignancy. And this is the ultrasound evaluation at 2 years after the procedure. You see there is only a small scar on the capsule deriving from the treatment, but there is no evidence of the tumor. How to study the nodule after? Okay, the follow-up procedure is to consider for 1, 2, 3, 6, and 12 months, as I mentioned you before, with the lab tests, TSH, thyroglobulin antibodies, and with a very well done ultrasound examination evaluating the volume of the necrotic part and of the residual vital part of the nodule. Evaluating with this formula the volume reduction of the nodule after the treatment. How to follow up? You can perform with the color Doppler, power Doppler, or with combined evaluation, flow, B-flow plus HD color Doppler, or with SonoView with the CEUS, the contrast enhancing imaging, that is not so cheap for this use, but if you have, you can use it. Actually, we use contrast enhancing imaging for the evaluation of the malignancies in order to have very well done follow-up evaluation during the follow-up. Some words about informed consent. Okay, for each patient, you need to that the patient will sign a very well done informed consent that should be given to the patient some days before, not the same days of the procedure, explaining everything and also about the complication that you had in your expertise. But regarding the complication, how to prevent complication, because this is one of the most important issues of this treatment, because you have to consider that the difference between a skilled operator and not skilled operator is that the skilled operator is able to avoid that a temporary complication will be a definitive complication. So it's very important, the experience and all the steps that you need to observe during the procedure. So consider that most of the complications spontaneously recover. None of them are life-threatening. You can use steroids if needs. The hydrosection is very, very important to perform and to reduce the risk for complication. And it's also important to consider that if you hear any voice change or something during the procedure, please stop, complete the procedure when the complication is observed, and full evaluate everything. So observation, US monitoring, translaryngeal ultrasonography to evaluate the vocal cord movement, ISPEC, and compression. All the complications are very well defined in some reports from literature. Most of them, as I told you before, are not life-threatening, absolutely, and are temporary. But we need to know what are the most frequent complication. One of the most critical complication is the nodule rupture. I have some cases from some doctors all around the world. This is a case from Dubai, with a young lady presenting this mass after the procedure. And you see here that the nodule rupture was developed in 2-3 weeks after the treatment, and that all the content of the nodule exiting from the capsule in the subcutaneous area increased the volume of the nodule, and at the same time was very painful for the patient. In this case, what you have to do, you have only to observe, to give the patient anti-inflammatory painkillers, and not there is no need for antibiotics, because this is not an abscess. This is another case from UK doctors, a very large nodule that was treated, and 6 weeks after, you see here the nodule rupture, and then the tissue, colliquated tissue exiting from the capsule in the subcutaneous tissue, creating a very big mass, very painful for the patient. In this case, the colleagues that I were to be very careful about the follow-up and not to insist the nodule because it is not an abscess, but the surgeons in their hospital decide to insist and then to do some examination for cultural assays that demonstrated that was not an abscess, but only a colliquation of necrotic tissue, demonstrating that, as Professor Beck told, that was revealing in his experience many times, that the nodule rupture is due to the microbleeding continuing to evolve after in the follow-up after the procedure, leading to the leakage from this content, from this colliquation content from the capsule going to the subcutaneous tissue. So this is not an abscess, it's not an infectious disease, and should be treated only with a conservative treatment and not with a surgical treatment. Another very bad complication is the skin burn, that is a consequence of the wrong appliance of the introduction of the needle along the long axis of the probe and not the short axis. Because with microwave, you can have, mainly with the old generator algorithm and the old devices, a flow of energy backwards you cannot observe if you don't insert the needle along the short axis, where you can see all the length of the nodule. And in this case, obviously, the complication, it was very, very not comfortable for the patient, not very well accepted, because we try to do this in order to avoid a scar, but the scar that we have with this complication is very, very bad. Another complication could be the Horner syndrome, so ptosis, meiosis, and anhidrosis. It's due to the thermal effect that we can have when we treat the posterolateral area of a nodule very close to the ganglion. So in this case, it's very important to consider the anatomy of the neck. This is a case of a patient that was treated in Abu Dhabi. You see the lady that was that reveals immediately during the procedure this Horner syndrome on the left side, on the left eye, and she was very, very concerned. Sorry. She was very concerned about the complication, and the colleagues asked me to give some information, and obviously I told him to give the patient some corticosteroids, painkillers, anti-inflammatory drugs. And you see that immediately after the procedure, immediately after the starting of the therapy, the complication reduce its entity. So the lady starting again to smile, and after 1 month, this is the aspect of the complication on the left side. This slide only to demonstrate that most of the complications are temporary, and that's very important to be skilled to prevent that temporary complication could become definitive complication. I finished, and I would thank you very much for your attention. And if you are interested to join us in our project, the Save Your Thyroid project, you can shot to this QR code and link to the website of Save Your Thyroid Foundation. Thank you. Thank you again.
Thank you, Professor Spiezia, for this enlightening presentation to share their great experience on microwave ablation in thyroid. We have collected some questions that have been popping up in our chat box. So the questions. Dr. Spiezia, could you please
Yes.
address the queries? Yeah, please.
Yes. As I mentioned before, if you have in your disposition the CUS, it's very good way to evaluate the effects of the therapy. We use it due to the cost of the SonoView. We use only for malignancy in order to well evaluate the effect of therapy with microcarcinoma and mainly with the lymph node metastasis that we treat. So when we treat lymph node, we perform a contrast enhancing with half a dose of SonoView before, and then the other half of dose after the treatment in order to understand if we fully treat the malignancy. You understand that for malignancy, we need to be very, very sure that we fully treat all the nodule. Then we have a second question. Can I go on? So what are the main differences between RF and microwave in terms of pro and cons aspects? Well, I think that both radio frequency and microwave work properly. And in terms of differences, I can say that microwave, when compared with radio frequency, is more fast and is more effective when we treat solid compact nodules, because to the fact that microwave is less dependent from the sink effect. So that when we have very solid compact nodule, I prefer to use microwave. Consider that in my hospital, I have all the thermal ablation devices, so I can do everything. And in my activity, I can decide to use one or the other technique, tailoring the treatment according to the characteristic of the nodule, the shape, the size, the position, but mainly from this decision depends from the ultrasound characteristic of the node. So for solid compact, I prefer microwave, while with spongiform nodule, they work the same, and both energies are very effective in order to reduce the volume of the nodule. Regarding complication, there is no difference because it's a thermal effect, so the thermal effect could be the same, inducing complication for radiofrequency and for microwave. Then we have the third question. Do you do for multinodular goiter? If yes, in one session or different times? Well, this is a very good question because nowadays we don't consider only the single nodules, as I mentioned you before, but also the multinodular goiter, because we consider the concept of the mass. So we go into the mass independently from the number of nodules, treating the mass. So it's not important the number, but it's important the position. It's important to consider to treat multiple nodules, but in the same lobe. We don't do treatments bilaterally in both lobes. We do always a single lobe for each session. So if the nodule is very big, if the goiter, the multinodular goiter is very big, up to 40, 50 milliliter, we could be able to treat in a single session, but sometimes we have very bigger nodule, we can split the treatment in multiple sessions in order to achieve the best results, considering also that if you treat small nodule, the volume reduction is greater than when you treat bigger nodule. So you need, in some cases, to come back again with a new treatment. This is a strange question because usually they ask me what is the greater nodule, not the smallest. Well, smallest, but anyway, it's a very good question because regarding the volume, you can have a very small nodule that, for example, in the center or in the deeper part of the lobe could be not considerable for treatment because too small. We could have a 1 centimeter, 1.5 centimeter nodule in the isthmic area that is producing discomfort, aesthetic discomfort for the patient that you can treat. So I think that 1.5 centimeter is the limit to consider, not smaller than this, but it depends from the position of the nodule, from the discomfort that this nodule can produce for the patient. Then what about hydrodissection? Well, I mentioned you the technique of the hydrodissection that we don't use usually to perform from the trachea to the nodule in the medial aspect of the nodule, except when we have, for example, treatment of microcarcinoma that are close to the area of the laryngeal nerve. In this case, we produce hydrodissection. We do hydrodissection in this area when we hear a voice change. In order to avoid the complication in this area that could be definitive, we stop the procedure and we inject cortisone and cold dextrose or cold mannitol between the trachea and the nodule in order to avoid this complication and to protect the nerve, because usually it's not a direct thermal effect, but it's only the compression due to the edema, or in some cases the increase in temperature, but not the definitive thermal damage of the nerve if you observe the recommendation for the treatment in order to be safe, so saving the dangerous triangle and the deep posterior area of the nodule. Then the sixth question is, do you do in Bethesda 3 nodule after 2 FNA 6 months apart? Yes, I started to do this treatment for Bethesda 3 nodule with 2 consecutive fine needle aspiration biopsies that confirm the type 3, but we also consider this patient for genetical tests in order to understand if some mutation were present in this case. So we decide to treat Bethesda 3 only if we don't have any mutation, okay? But if we have an HRAS, KRAS mutation and so on, we prefer not to treat them. Yes, for the 7th question, of course, we perform master classes for everyone: endocrinologists, intervention radiologists, surgeons. The master classes are planned during all the year, and if you are skilled with ultrasound examination and you are skilled with fine needle aspiration biopsy, you can register for one of these courses on microwave ablation that are usually supported by Kenyan company. During this procedure, during this session, we, in the first part, start with the scientific presentation, then with the training, with the hands-on session on the models, on the phantoms, and we continue with the showcases in the operative room. We will discuss about the cases that we will treat. Then we treat the cases in the operative rooms, and you will see the treatment that are done by me or by my colleague, Dr. Giovanni Antonelli. This is the step, the fundamental step to observe. Then a further step could be the percepting. In other words, it means that you can share with us, with my center, the cases that you think that could be candidate for treatment in your hospital. We can discuss about this case, and you can start to treat them, asking us to go to your hospital and being very close to you, besides you, in order to guide you in the procedure, to be safe for at least the first 2 or 3 procedures. Then you can go on and proceed by yourself with the femoral ablation procedure in your hospital. Ciao Tommaso.